So before we go to the treatment detail, we should know the pathophysiology of migraine. So now the theory is it's a hypothalamus activation which starts off your migraine. So the hypothalamus sets off what is called as a cortical spreading depression. Okay, so this cortical spreading depression, some people now say it is activation, spreads across the cortex. And when the depression reaches your trigeminal vascular system, that is when the whole cascade of migraine starts. So this activates the trigeminal sensory efferents, which is, these are the trigeminal sensory efferents are the main supply for most of the pain related structures in your brain. So when this happens, there will be an inflammatory change occurring at the trigeminal sensory efferents in all the pain structures in the brain. So you can see this is a trigeminal nerve which supplies the cerebral vessels, spiral, dural matter and large venous sinuses, which are all pain sensitive structures inside the brain. Now what happens at the trigeminal nerve ending? So this is very, very important to understand how we can treat migraine. So you have the trigeminal nerve ending which is coming, and it releases various inflammatory markers. The first thing is serotonin. The second, very important, something called calcitonin gene related peptide. And the third thing which the trigeminal nerve ending releases is something called pituitary adenyl cyclase activating polypeptide. But the most important are the serotonin and the calcitonin gene related peptide. Now these inflammatory these substances which is released acts downstream to the vessels and causes vasodilatation and sterile inflammation, and this is what causes your headache. So this is an important thing to understand when you start treating migraine. So now if you look at the phases of migraine, most of this can be explained by this theory of trigeminal hypothalamic activation. So the initial prodrome where you have craving of certain foods, tiredness, everything can be related to your hypothalamus which is getting triggering. Then you have the aura. As the depression is passing over your cortex, you get different types of aura. If it is passing over the occipital lobe, you will get visual aura. If it is passing over your motor cortex, you will get motor aura or sensory aura. And then you have your trigeminal vascular system getting activated, where you get your headache due to release of these substances I just mentioned. And then you have your, so even normal, these patients can have some problem in the hypothalamus. That is why they are slightly different from any other normal individual, the migraineurs. Right. So it's very, very important for all patients with headache to keep a diary and note down which all days they are getting headache and what is triggering. So as I mentioned, episodic migraine means less than 14 days a month, and most of the time you see patients having episodic migraine. Now, if this cycle is getting repeated every other day, what can happen is there is something called sensitization happening. And then when this happens, there is the neurons become more sensitive and responsive to even non-nociceptive stimuli, and this can lead on to what you call as a chronic migraine. So it is very, very important when you have a patient with migraine that you should not you have to prevent this patient from going into a phase of chronic migraine, because chronic migraine is something which is not that easy to treat. And moreover, some of these patients with chronic migraine can keep on taking medications, and they can have another thing called medication overuse headache along with your chronic migraine. So this is very important that you cut short the episodic migraine, treat the episodic migraine, and that's it. So treatment consists of three things. One is lifestyle modification, treatment of the acute episodes, and prophylaxis. So what are the targets of treatment? First, you have the activation of the hypothalamus itself. Basically, that is avoiding all triggers for migraine. So these are the common, so you have to make sure they have lifestyle modification, identify what that particular patient's trigger is, and then avoiding those triggers. That's the first thing you should be doing. The second target is targeting the inflammatory changes at the downstream. So here, so you have three targets here. One, before the inflammatory mediators get released from the trigeminal nerve ending, once they are released, and at the downstream. So we'll just look through these three areas one by one. So what are things we can do once it is getting released? We can give them NSAID, which will take care of your inflammation. So you use any of the NSAID which is suitable for that particular patient. And usually one of the good NSAID which we usually use is naproxen, ketoprofen or ketorolac. The second thing is triptans. So triptan acts downstream. Why? Because it causes vasoconstriction. And also triptans has some action upstream by inhibiting the release of neurotransmitters. So this is how triptan works. And you have a whole lot of triptans in the market now. And it comes in various forms: tablets, subcute, nasal spray, nasal powder, oral wafers. So whichever is possible you can give to your patient. So here history is very important, because if the patient has a history of prodrome, so you can make sure that patient takes your triptan during the prodrome. So that's why it is coming in this nasal spray as well as oral wafer. They can carry it in their pocket. They know that they are going to get the headache, they can take it. So that's why, as I told you, that the phases, to understand the phases is important. Right. So the limitation of triptan is you should not take it more than 10 days in a month to avoid what you call as a medication overuse headache. You can, because it causes vasoconstriction, you cannot use it for patients, somebody is having a coronary artery disease or who has recovered from a stroke. And also in patients with what you call as a hemiplegic migraine or migraine with brainstem aura also, you can't use it like in other patients. Right. And most of the time we can use a combination of triptan and NSAID to be more effective. So it is targeting two areas downstream, both inflammation as well as vasoconstriction. The next we have antiemetics, which also can be used for migraine. The most commonly used is metoclopramide, and especially if the patient has nausea or vomiting along with the attacks, you can add one antiemetic also with your NSAID. Next you have ergotamines, which is hardly used now. You use it only if nothing works, because it causes severe vasoconstriction and can cause problems. Next you have beta blockers, which again causes vasoconstriction. It blocks the nitric oxide synthase from the endothelial tissue. Again you have a whole lot of beta blockers which you can use. The commonly used is the propranolol. Next you have medications which acts once the neurotransmitters are released. So here there are molecules which can target your serotonin, that is amitriptyline and fluoxetine. So both of them acts by inhibiting the reuptake of inhibit the serotonin and noradrenaline reuptake. So basically the action of serotonin is stopped there. So amitriptyline we can use up to 150 milligram per day. But there are some antimuscarinic effect when you use these agents. Next we have a newer class of drugs called dietans. The most commonly which is in the market now is lasmitinib, and again it acts at the serotonin 5-HT1F receptor. And the good thing about lasmitinib is it lacks the vasoconstrictive activity, and that can be, so you can use it even patients who has cardiovascular risk factor. Okay, so only caution here is they can have some drowsiness, so you should not be driving after up to 8 hours once you take this lasmitinib. Next you have an important group of drugs acting on the calcitonin gene related peptide. So you have GPANs, which are in fact receptor agonist. This acts at the calcitonin gene related peptide receptors and blocks the receptor. So you have oral tablets for this, the class of drugs called GPANs, and we can give this drug for patients who have failed on triptans or who are unable to tolerate triptans. And again you can have, they do not constrict the cardiac or cranial artery, so it is safe to use in patients with ischemic heart disease or cerebrovascular disease. So another good thing about GPANs is they can be used for both acute migraine attacks as well as for preventing migraine attacks. Next, we have monoclonal antibodies which can actually target the calcitonin gene-related peptide itself, and but these are all to be given either subcute or infusion every 3 months. This is not yet available in India. Next, you have monoclonal antibody which again targeting the CGRP receptor. So these are monoclonal antibody. GPANs are not monoclonal antibody, they are just antagonists, just sitting on the receptor. So here we have a drug called Erinumab. So this is just have to give this injection once a month, 70 milligram subcute once a month, and that's it. Like, so the patient, you can treat this can be your preventive treatment for migraine. So as you see, there are a lot of molecules acting both downstream and at the middle level, and we have some agents which can act upstream to prevent the transmitter from getting released. These are all our old agents like flunarizine, which are calcium channel blockers. You have topiramate, again it decreases the release of neurotransmitters, sodium valproate, anti-seizure drugs, and also botulinum toxin. So what is the action of botulinum toxin? It prevents the vesicles containing the neurotransmitter from attaching to the synaptic surface and releasing the drug. So botulinum toxin is another option for chronic migraine patients. So if you look at this cartoon, you can see the various options we have to treat migraine, both upstream, middle stream, and downstream and upstream. So if you look at most of the patients with episodic migraine, you just need only lifestyle modification and treatment of the acute episodes as they happen. But some patients who have gone into the chronic phase, then you might have to start them on migraine prophylaxis. So you have to choose your patient, which patient you might start on migraine prophylaxis. It depends on the frequency. The first thing is the frequency, how severe the attacks are, and the duration, and whether each episode is incapacitating the patient or not. That's the most important thing. And other features like associated nausea, vomiting, vertigo. So suppose you have, say, a driver who's getting only 2 episodes a month, but for him that 2 episodes may be incapacitating. Each episode can last for 8 hours. He can have dizziness, etc., which can prevent him from potentially driving. So those patients you have to give prophylaxis. Whereas some other, say, housewife who's not, getting episode, even if it is a severe episode, she can take off and take rest. So you might not start prophylaxis. So which patient you start prophylaxis depends on these 5 features. So if you want, you can use this Midas questionnaire. You can give it to the patient and ask them to fill it and give. So you'll know how severe the episodes are. And as I told you, it should be individualized pharmacological episode. Also look at the comorbidities the patient is having and the presence of other drug tolerance also when you choose your drug. So if you look at treatment of acute episodes, you can use all these drugs to treat acute episodes: NSAID, antiemetics, triptans, GPANs, and lasmiditan. If you want to give prophylaxis, you can choose the upstream and other molecules which are acting in the middle for migraine prophylaxis. Now, for chronic migraine, you can use other modalities also. There are a lot of neuromodulatory interventions which we use now for what you call as this chronic daily headache. You can use transcranial magnetic stimulation, transcranial direct current stimulation. You can use vagus nerve stimulation, etc. 2 things I just want to mention here. One is transcutaneous stimulation called cephali. So this stimulates the supraorbital branch of the trigeminal nerve, and the patient can themselves use this device and can be used for both aborting migraine attacks as well as for prophylaxis to be used. Every day you can use it for prophylaxis. Again, in India we have a device called the Nerivio device. This can be worn on your arm, and this is a wireless remote electrical neuromodulatory device. So understanding individual patients' headache features is very, very important when you treat the patient. And you have to prevent an episodic migraine from getting converted into chronic migraine. And always use a combination of the medications. Okay. Now you know various targets. You can pick up 2-3 targets and start using and target multiple pathologies causing migraine simultaneously. Thank you.